Góða kvöldið og velkomin á KLA-TV. Dr. Suzanne Humphries bandarískur lyfjalæknir og nýrnasérfræðingur sem starfar óháð lyfjaiðnaðinum. Yfir áratugalangt starfinnar sem læknir fékk hún að sannræna að hefðbundnar lækningar framleiða oft ný veikindi í stað þess að lækna fólk. Niðurstöður áralangra rannsókna á bólusetningum á smitsjúkdómum birti hún síðan í bók sinni Saga bólusetninga, blekkingar og tálsýnir. Þar varpað fram mikilvægum þáttum sem almenningi lítt kunnugt um. Á meðan að fyrirlestraferð hennar Norðurlönd árið 2015 stóð, hélt Dr. Humphries fyrirlestur í Íslandi viðfangsefnið leynda staðreyndir bólusetningar og aukaverkanir þeirra. Á grundvelli nýlegra vísindalega rannsóknar sýnir hún að framundan sé endurnýjun á núverandi kennsluhugmyndum hvað bólusetningar varðar. Því, og hér kemur tilvitnun, vestræna læknisfræði hefur hingað til sagt okkur að læknisfræðilegt inngrip í formi bólusetninga hækki lífsgæði okkar og komi í veg fyrir sjúkdóma. En það sannleikanum samkvæmt? Hér á KLA-TV getið þið hlusta á enn aðra óháða rödd hvað bólusetninga varðar sem hjálp til persónulegrar skoðanamyndunar.
So 1 or 2 breaks, and then we will have questions and answers. And I hope that I can answer all of your questions before you leave, because I'll be telling you what I think you should know, and then I'll tell you what you came here for if I don't get it in this talk. All right, so I call this talk Vaccine Re-Education, and it will become evident soon why I chose this name. But first I would like to start with some of my history. In case you don't know, my name is Dr. Suzanne Humphries, and in 2011, I left the mainstream hospital medical system after working for some 17 years as an internist and nephrologist and being board certified. And up until then, I was micromanaging a group of patients who have kidney failure. And if you don't know, if you have kidney failure, you're pretty much stuck between a rock and a hard place, and it's a very difficult position to be. And I very much enjoyed my work, working with kidney patients, and I didn't leave because I didn't enjoy my work. And many doctors avoid the topic of nephrology or kidneys because it's very complicated. But they're very fascinating and vital organs, and without them, your bones, your blood, your lungs, and your brain just won't function normally. So, like most doctors, I was educated, or at least I thought I was. As any doctor can tell you, medical school education is kind of like drinking from a fire hose. But because I was a glutton for punishment, medical school was actually my second fire hose drink. The first was a university degree, and this was me back when I was young and fresh and without gray hair and wrinkles, while I was earning my physics degree. My bachelor in physics, and I later graduated and I ran a lab that specialized in nerve microtubule research. But I really wanted to work with people, so then I went to medical school afterwards, and I specialized in internal medicine. After my residency, I realized that internal medicine wasn't all I really wanted to do, so then I specialized again in kidneys or nephrology in Philadelphia. Then I became an assistant professor of medicine, and I taught various levels of doctors and students, and then I later moved on to a private practice in a large teaching hospital. And I sat around these years listening to doctors who said things like, Paul Offit says that 10,000 vaccines can theoretically be given all at once to babies. Paul Offit is a medical doctor in the United States, if you're not aware of this, who sets vaccine policy and who is also a vaccine inventor. I heard things like, the anti-vaccine people are a threat to human survival. And I heard things like, aluminium is important for the growth of a healthy fetus. So these are my academic qualifications. Yes, I thought I was educated. After all, I checked off all the right boxes, and I passed my board qualifying exams, and I had all my degrees framed on the wall. And I was living in paradise. I had an office overlooking a river and wilderness. I made my own hours. I used to say, pinch me, is this really my life? So what more could a successful specialist want? I had it all. Well, I also had a lot of business as usual. And after a period of time, reality didn't line up with my education. I had been a nephrologist for quite some time when suddenly, in 2009, I saw something different than I had seen in previous years. In a relatively short period of time, I saw several patients with kidney failure that developed after receiving their outpatient influenza vaccines. And I started hearing repeatedly that their problems started after being vaccinated. And I noticed this was also happening in the hospital after vaccines were given on the day of admission, while people were seriously ill, or shortly after. So the slide that I have up now is from a patient who had some mild kidney impairment at baseline, and he was admitted for a totally unrelated issue. He was given the quadruple 4x strength flu vaccine for the over 65 age group on his 4th hospital day. And on the graph you can see, denoted 9/25, he developed kidney failure within 24 hours of getting vaccinated. And what you see here is something called creatinine, which is a measure of your kidney function. The lower, the better. And then he got his vaccine and he went very high. So it took several months for his kidneys to settle back down after this, and no other doctor could find any other explanation for this happening. And in my opinion, it was due to the influenza vaccine's inflammatory effect upon his already suffering kidneys. His kidneys returned to about 60% of his former baseline. This is another case of a woman who had a ruptured intestine, and then she went to the operating room, and she was doing quite well, actually. And then 5 days after she was operated on, she was given 2 vaccines, one for flu and one for pneumonia. So she basically got some mercury and some aluminium and all the inflammatory components that go with that. Upon which her kidneys shut down, and she was started on dialysis, which is why I was called. She ultimately regained about 60% of her kidney function and was sent to rehabilitation. But then she returned a few weeks later with new onset seizures or epilepsy. She died in the hospital. These are only 2 of the many people I cared for who had serious life-threatening complications immediately after their vaccines, most of whom volunteered to me. I was fine until I had that vaccine. And I have all of their case reports with me, but I didn't want to trouble you tonight with all of them. So I wondered if I had just been blind before 2009. And it's possible that that was part of the problem. But I found another explanation, that hospital policy had been changed to vaccinate as many sick patients as possible on the first hospital day, or any contact with the hospital. So it's one thing to vaccinate healthy people, but it's a whole other thing to be injecting vaccines into people in the middle of a heart attack, a stroke, cancer that's under treatment with chemotherapy, sepsis, or acute serious kidney problems. But what I call opportunist vaccination, meaning vaccinate people when they're available in the hospital, is the practice today in the USA. Since 2009, a pharmacist would go into the patient's room. They would show them one piece of paper from the Centers for Disease Control that had very limited, very biased information, and the pharmacist would offer them 2 or more vaccines. If the patient consented, and most of them did, an order was put into the computer with the attending physician's name on the order before a doctor had even seen the patient or before a diagnosis had been made. The nurse would give the vaccine. Sometimes that order had my name on it, even though I would never have ordered a vaccine, and I would not have signed the order. So needless to say, I was quite distressed over this, as I would have been any drug given to one of my patients without my approval. So I decided to speak to the hospital management about what I was seeing. So one day in the corridor, I bumped into the chief of medicine, and he asked me how things were going. And I detailed what my concerns were about the flu vaccinations and what I was seeing in kidney patients. But according to him, I was the only doctor who had concerns or was seeing these problems. And he kept responding to me as if the science was settled. So I got the full-blown historical justification. Vaccines have eradicated smallpox and polio and meningitis, as if that had any relevance to vaccinating sick adults in the hospital, some of whom were at death's door. So I put my concerns in writing, and meetings were held to discuss this issue, but I was not invited to them. The result was that I was told that acutely ill patients in the hospital would continue to be offered vaccines on arrival at the hospital. And I asked myself, exactly what is the science that says that these vaccines are safe for really sick people? There must be studies on the subject and writings in the medical literature in order for them to be so sure of the rightness of their policy. After all, it's science we're talking about, right? So, if the science is supposed to be all settled on the safety and effectiveness in vaccines, I should have found something. So I went and I looked and I found zero science and reported that back to the chief of medicine as well. For over a year, I discussed with the administration and my colleagues my research findings, the science that was there, showing that there could be harm, and the increasing numbers of problems I was seeing in my own patients, and sometimes in my colleagues' patients who were unwilling to discuss them themselves. Other doctors were starting to change their previously set minds and seeing reactions in their patients, and a high number of nurses were catching on. Because I wouldn't back down, and the hospital management then invited in an expert to set me straight. He never addressed any of my questions regarding acute kidney patients or acutely ill new hospital admissions. He gave me a list of studies showing that some vaccines raise antibody levels in most people with HIV or kidney failure. And his argument was that because of that, for acutely ill kidney patients with sepsis and heart attacks and Guillain-Barré syndrome or cancer or urinary tract blockages or serious kidney diseases, that vaccines were also perfectly safe. His letter was very bizarre. I have a copy of it here. And I kept thinking, and this is the expert? Why can't he answer my specific concerns? Where is his proof that side effects don't happen to my patients? Nowhere could I find studies that looked at vaccines in acutely ill patients commonly seen by kidney specialists. Even my pro-vaccine colleagues agreed that there was no scientific basis to give these injections so quickly upon hospital admission, and they supported my motion to have the policy changed to vaccinate on the day of discharge. But the executive committee of the hospital disagreed. And they told me that it was not appropriate for me to stop vaccination orders on my patients, and that I was confusing the nursing staff. And I thought, how bizarre. Nurses are never used to the same treatment plan for all patients, ever. Many were relieved to find a doctor who was actually looking and thinking and seeing the same problems that they had seen for even longer. Among the nursing staff, there were more allies than I would have ever imagined. But the hospital administration robotically argued that evidence for benefit of vaccination is overwhelmingly positive and evidence from harm is negligible. No one in the hospital ever addressed my specific arguments, and all I got was the result of their education, which amounted to sound bites. Statements like, vaccines are safe and effective. Smallpox was eradicated by vaccines. Polio was eliminated by vaccines. While looking at a person who has seriously deteriorated after a vaccine shows total scientific disconnect. I was stunned by the lack of clinical interest or acumen. It was this type of dismissal that made me realize that perhaps there was a lot more to learn than I had previously assumed. This realization threw me into studying the medical literature more thoroughly, and then 2 years later going into full-time research and speaking to the public and to doctors about my findings. I have a YouTube channel, and you can see more on why I left the hospital in the series that's there. You can see information on infant immunity, on aluminium, on different types of vaccines that I have lectured on in the past, and also on some other vaccine critical doctors from the 1950s in high-level positions in the United States, in a series called Honesty versus Policy. So after leaving the hospital, I started researching diseases and medical data and the public health medical literature. The result was a book called Dissolving Illusions, which was co-authored with Roman Bystrionic, which presents information from medical literature and history which casts a completely different light on what the medical system considers to be education. It has been picked up by German and Spanish publishers and recently was translated into Icelandic. Because I have found out firsthand that the message coming from the mainstream is corrupted and backwards, it came as no surprise to me to see this recent article, which calls for the re-education of parents who won't vaccinate their children. Apparently, the problem with these parents is misguided thinking, misinformation, and a false perception of fear based on anecdotal thinking. Gary Marshall, who is pictured on the right, says that altering anti-vaccination attitudes requires re-educating vaccine-refusing parents and caregivers to change how they think about the relatively low risks related to vaccination. Plainly, Marshall is a career vaccinologist who admits to income from vaccine manufacturers for doing vaccine efficacy trials and being on their advisory boards. Marshall is doing what he's paid to do, just as I was doing what I was paid to do. But there's a big difference between issuing edicts from a golden tower while getting supplemental income from 5 different vaccine companies versus watching your patients fall apart after being injected with a vaccine supposedly ordered by you. As I re-educated myself in the medical literature, I was appalled at the ignorance all around me, which I once held as well. What do I mean by that? I mean doctors who have no idea what they don't know, but who have an air of arrogant certainty anyway. They believe what they are taught and rarely, if ever, look for themselves what the actual medical literature says. But then the religion of the system depends on that. The more I learn, the more I realize that it's the medical profession and academia that are in urgent need of re-education. But that isn't likely to happen when the priorities are focused on money, reputation, and research into an industry which now has the marketing mirage of a holy grail. And if you research the pro-vaccine literature, indeed all vaccines are considered to have once been the holy grail. Smallpox vaccine was considered to be the holy grail. Polio vaccine was considered to be the holy grail. And excited professors like someone named Louis Galambos of Johns Hopkins University, in partnership with the UK Vaccine Industry Group, asked this question in purple: what are the prospects for a new golden era in vaccines? In this document, he talks about the first golden era. And this is a term you'll hear over and over when you listen to vaccinologists today. This document is a blinkered, potted history of where vaccinology has been and is going. The sentiments are exactly the sort of one-eyed self-interest you would expect from all the stakeholders in industry who are salivating almost uncontrollably. Such holy language as this isn't restricted to the public media. It's also the view of leading key opinion people. The message to the public today is that the science is settled on everything vaccine. But as I compared the so-called evidence with the historical and scientific literature, it became clear that the education given to me and to doctors today is an oppressive form of religion, preached as gospel by leading authorities who act as if their very narrow truth is the only righteous belief to have. When you see one of the foremost pro-vaccine priests, Gregory Poland, proclaiming a long-lost 11th commandment to doctors in an online tutorial, you should consider that it's more than just a joke. Explaining the broader concepts as I'm doing today is to them akin to heresy, even if the information I'm telling you today is right there in their peer-reviewed medical journals. The question is the vaccine education that we receive as doctors and the information that you are given as parents based in a holy grail myth which protects the sacred cow? My educated opinion is yes, both are true. One of the arguments to medical personnel in hospitals is that flu vaccines should be mandatory because we must protect our patients. So let's look at the realities of herd immunity. inactivated polio vaccines, diphtheria, tetanus, and the New Zealand meningitis B vaccine don't stop a person transmitting bacteria or virus. So these vaccines here were actually never designed to protect herd immunity at all. If you get an injected inactivated polio vaccine, you swallow a polio virus, it's still going to come out the other end of you and be able to infect anyone around you. Okay, so there's no herd immunity, nothing stopping the spread of this virus. Tetanus. Tetanus is, it basically causes you to create an antibody to the toxin that the bacteria can make under certain conditions. Does not, you can't pass tetanus from one person to another very easily. I've never known of a case where that happened. And the tetanus in the soil is not going anywhere. It's here to stay. Diphtheria is a vaccine that is against a toxin. So again, the bacteria is still perfectly viable in the environment. So, and then we have the meningitis vaccine from New Zealand, which is somewhat infamous. It's very interesting if you ever want to read this vaccine, which was invented in Norway and then brought to New Zealand, and it was a disaster. But in the end, they realized that even though they had vaccinated some millions of people with it, or given millions of doses, I should say, that people were still carrying the bacteria in the throat. It was a total waste of money for the New Zealanders. So herd immunity is also well known to be limited with the following vaccines. Pertussis, which I will get into in a short while, causes something called original antigenic sin, which I did not create that term. Mutant strains have come about. The pneumococcal vaccine has problems with, it's very accurate at getting rid of the strains of bacteria that it targets. But the problem, it's like going out and shooting all the white rabbits outside. What will happen is the black rabbits will take over. And that's what happens with this bacteria. Haemophilus only covers one strain, same thing. Other strains are taking up that space. And Gardasil, besides being an absolute disaster in the girls that it's injected into and some of the boys, we have the same problem where the vaccinated are having new, more carcinogenic strains moving in to the space that was left over. And medical literature shows that. It's not controversial. But ironically, new research shows that herd immunity doesn't even work with the flu shot. Flu shots are inactivated and contain particles of different strains of flu viruses, except for the kind that you inhale. I'm talking about the injected kind, the most popular kind. So these injected flu shots might help you the year you get them if you have a perfect match to the circulating virus, if you make strong antibodies against it, which not all people do. But vaccines like this do not make T cells towards the virus, which is the most important aspect of protection against different strains of influenza. I'm going to get back to T cells and antibody in a minute, so just take this right now as I put it out in front of you. So this study by Hayward, I have PMID numbers on all of my studies. That means you can go and look them up yourself and read them on the PubMed internet site. So this study by Hayward looked at 1,400 unvaccinated people and followed them over a flu season. And the results of this paper will startle anyone who thinks flu shots help the community or the individual. In Hayward's analysis, T cell levels and antibody levels were measured both pre and post-infection. Okay, so they followed these people out, they got some baseline blood results, and then they got follow-up blood results on people who got infected. And 43% of this unvaccinated population that was studied had baseline T cell responses against influenza. And this is really important because it's the T cells that protect you from multiple different strains of flu virus and help you the most. This study found that the unvaccinated had really high cross-protective responses to other flu strains, and that only 1/3 of naturally immune people, when infected, shed virus after their infection. A 2/3 reduction of viral spread is a big deal. It's a 66% efficacy for doing nothing as they pointed out. It's an important population-level effect. Remember that viral shedding is associated with disease severity and infectiousness. So here we have the ironic situation where it was the people with natural immunity who had an important population-level effect, not the vaccinated people. What makes this situation worse is that the T-cell responses are the explanation for non-spreading asymptomatic infections, not the antibodies. The antibodies these people had were not close enough matched to protect against circulating strains. So let's think about it. Who is protecting the herd better? Those with specific antibodies or those with T-cell cross-protection? Let's look at some other medical journal analyses. This one looks at both vaccinated and unvaccinated children. And the authors were curious because they knew that in 2009, in that epidemic, those who had previous flu shots were at an increased risk of infection with that 2009 pandemic strain. So they did a study looking at 27 unvaccinated and 14 vaccinated children. What they found was that 89% of unvaccinated children had antibody against at least one strain of flu. And not surprisingly, 100% of the vaccinated children had antibody against at least one strain of flu. So okay, the vaccines give you better antibody. But vaccination produced specific antibodies but interfered with the CD8 T-cell response, the part that's helpful in remembering not only the strain that you were infected with, but is able to react to other strains as well. They show that the pediatric flu vaccine antibodies actually hampered or inhibited development of T-cell immunity. Is that what we really want? These studies listed here all show that vaccinated children are worse off. Unvaccinated children develop T-cell immunity that is comprehensive. Vaccinated do not. The vaccine, as I said, prevents CD8 T-cell immunity. Unvaccinated children are better protected against multi-strain flu viruses than vaccinated children. Unvaccinated children have a higher likelihood of asymptomatic infection and shed less virus. Unvaccinated children have higher numbers of cross-reactive and specific CD8 T cells. Vaccine antibodies prevent this. Unvaccinated children are less susceptible to yearly flu infections than vaccinated children. They have a lower risk of pandemic infections than yearly vaccinated children, and it says so right in these articles. So the reason vaccinated people in general are worse off is that the virus-specific flu antibodies don't recognize other types of virus. And we know that you hear every year how the vaccine is not a good match for the circulating strains, right? Now, if it was 100% match, that would mean that that vaccine could protect you from this year's flu. But it's still going to put you at a disadvantage in the future unless every year they get a perfect match and you get the vaccine. Virus-specific T cells, on the other hand, do recognize other types of flu viruses. And we also have something called innate natural killer cells that don't require any sort of previous infection or vaccination that protect you. And what we have is the conclusion that vaccinated animals suffered more from a challenge infection with a highly pathogenic virus than those not vaccinated. So they've studied it in animals on purpose, and they've looked at it in humans and noticed the same thing is true. And what we have here is a form of original antigenic sin, which means that the first way a person experiences an antigen is how the body will respond afterwards. And if the first way is the wrong way, then every time afterwards, the immune system won't work properly. And this is detailed very well in the book. So this is why vaccinated animals suffer more when new flu strains infect them. And the punchline of the paper is Inactivated vaccines induce virus-specific CD8 lymphocyte responses inefficiently, and annual vaccination with this type of vaccine may even interfere with the development of virus-specific CD8 lymphocyte responses, otherwise induced by natural infections. Now, someone with intelligence might ask this question. Since vaccines create an inefficient immune response, which interferes with the CD8 T cell response, which according to Canadian research puts the vaccinated person at risk of pandemic or other flu infections, what else could happen? Is there any benefit to the vaccine? If the vaccine compromises community immunity, why are we insisting that medical staff get flu shots to create herd immunity? Why do sick patients get injected with a vaccine that has such a dubious immunological priming the minute they walk into a hospital? In 2012, a flu vaccine trial was done, which astonishingly actually used a valid saline placebo. And if you don't know, the majority of vaccine trials will use another vaccine as their placebo, instead of using salt water, which is what should be used. And by using another vaccine, the difference between the groups will not be as great. But these researchers, being independent as they were, used a saline placebo. So this study is a groundbreaker because it followed people out over a whole flu season to see who got infected with what. So what we have here is trivalent influenza vaccine injected and placebo injected. Okay, and then when someone got sick, they did cultures of the throat and the nose to see what exactly they were infected with. If you look at seasonal influenza A, the placebo had more infections, okay? But if you look at influenza A, the vaccinated had more. This H3N2, the vaccinated had more infections, okay? If you look at seasonal influenza B, you can see the placebo had more. Look at this pandemic. Here we have the pandemic influenza, and you can see, look at this, the vaccinated had far more than the placebo in this one. And any non-influenza virus, this is the important part as far as I'm concerned with this study, because what this showed is that the vaccinated actually had a 5 to 6 times higher rate of infections with rhinovirus, Coxsackie, echovirus, and other respiratory viruses, some of which can actually be worse than a flu virus infection. So here's a vaccine that has little practical use, but which makes people who get the vaccine 6 times more likely to get sick than those who don't get the vaccine. And I know as a doctor working in a hospital that often vaccinated staff would come in sick and work sick. So how many hospital staff get an infection, like the people did in Cowling's study here, and then infect their patients with both flu and non-flu viruses as a result of being vaccinated? I don't know, because nobody's looking. This Cowling study isn't the first time that excess non-flu infections were found in vaccinated people. It was also found in a 2011 study by someone named Kelly, but they dismissed it as the result. They dismissed the result as being biologically implausible. So what else could hospital policies be administering that could also spread disease? Fever reducers. These drugs are automatically ordered in hospitals and used like water in clinics and hospitals. The medical literature is very clear about the fact that acetaminophen is detrimental in any infection and it's liver toxic. But the robotic use of fever reducers shows how little doctors know and think about what acetaminophen does, and in my opinion, how the immune system works. An individual whose fever has been reduced by a drug is likely to feel better and is therefore more likely to interact with others. In addition, fever suppression may increase both the rate and the duration of viral shedding, further increasing the pathogen's transmission rate, and this effect has been shown experimentally. Fever suppression increases disease severity and likelihood of death. Higher virus transmission rates will lead to larger epidemics and hence to greater morbidity and mortality. Dr. Ern's research and mathematical models led him to conclude that overall, fever suppression increases the expected number of influenza cases and deaths in the United States for pandemic influenza and for seasonal influenza, with the estimated increase is 5%. And he says that this is a very conservative estimate, but even so, 5% is a lot of people. Another important point is that from a diagnostic point of view, that masking symptoms also obscures the clinical picture, making an incorrect diagnosis more likely. It never surprises me when I read in the news about people dying from what seems like just a normal viral infection after they were given fever reducers. When you see these reports in the news, read them carefully, and you'll see this more times than not, that fever reducers were given, as well as antibiotics during viral infections. So the fever reducers can put anyone at a disadvantage, but the effects of fever suppression could be even worse in a vaccinated child because they're already likely to be sicker when they become infected with a virus that doesn't match their vaccine, because the immune system responds the way the vaccine taught it and not with the T cells the way those unvaccinated children respond. But back to all the studies which show that flu vaccines prime the immune system the wrong way. Why are these studies being published now, you might be asking? You might also be thinking that I found these in some fringe hippie journal that nobody respects, but actually they're published by very pro-vaccine scientists in mainstream medical journals in 2014 and 2015. The assumptions of those who made the flu vaccines were wrong, and the more these vaccines are used, the bigger this problem will become. Though you would never know there's a problem, the way flu vaccines are pushed on all populations, including pregnant mothers in America and elsewhere, and 6-month-old babies and just about everyone else. There's no public admission that the vaccines are actually making the spread farther. This knowledge is not new, but it's being discussed now because some of the details have been worked out. And as a result, new flu vaccines are supposed to become available that promote cell-mediated CD8 immunity and also antibody protection to stop the problems that they are now seeing and admitting to about the current flu vaccines. But the new vaccines will not fix the problems that have already been created in the millions of people who have had flu vaccines every year for decades and who are still being browbeaten into getting vaccines even as they know this knowledge. So how do you get around the fact that current propaganda to parents solely portrays the flu vaccine in pregnancy as an anti-autism vaccine, and the system is firing nurses for refusing to have flu shots, which can actually make them sick from other viruses? And what you see there is from an actual YouTube clip of one of the prominent vaccinologists in the United States named Gregory Poland, who said that exact quote. It's always been a well-known unwritten rule in the medical system that the only time you can talk about how ineffective something is when you have something better to offer. And now this is being said, at least in the medical literature, because just around the corner, there's a new breed of flu vaccines, which use something called viral vector systems. Now, you might be aware that the old vaccines were made in chicken eggs, right? And there's some new technology that I'll get to, but this is a special technology. This example here uses E. coli bacteria as the factory to make vaccine antigen that will be composed of a piece of the protein from the inside of the flu virus that's chemically bound to pieces of virus made from another non-human virus called Q beta, which they say is impossible to infect a human with. And this one is also turbocharged with aluminium. And mind you, the flu shots were some of the few vaccines that didn't have aluminium. So when they introduced this new flu vaccine, Everyone will just be told that a new and better vaccine is here, but not why the old vaccine had to go or what the problems with it were that they're actually having to live with today. So nobody will realize that the assumptions behind the current flu vaccines still being pushed on everyone were based upon a mirage, or even worse, possibly quicksand. And we won't know for another few decades whether the new flu vaccines have a different sting in their tails. We'll just keep being told that the science is settled, that vaccines are safe, effective, and necessary for pregnant women and 6-month-old babies up to old age every year. Where vaccines become compulsory, people will have no right to refuse any kind of vaccine technology like that, whether you like it or not. Like flu vaccines made on this tumorigenic Cocker Spaniel dog kidney. And if that sounds crazy to you, look it up. It's already on the market, as you can see by Time Magazine's excitement in 2014. In studying vaccinology, one can observe that just about every year there is a discussion of yet another patch to try to fix a problem they thought never existed. This is settled science. The herd immunity that doctors were taught 20 years ago bears no resemblance to the herd immunity of 2015, where the measles goalposts are now being raised to an even higher rate of vaccination than previously. 99% vaccination uptake and herd immunity was announced in 2015 as the goal. What Dr. Majumdar here doesn't appreciate, what famed vaccinologist Dr. Gregory Poland, who I showed you before twice, clearly said. Because the current measles vaccines has such shortcomings, you will never reach a level of 95% community immunity, even if 100% of people are vaccinated. Dr. Poland admits to that because his right hand is sitting on patents for a new generation of measles vaccine for his new golden era of vaccinology. And he's written this in his papers. In fact, I think he's even titled some of them. I repeat, the current MMR vaccine is not capable of eradicating measles. Dr. Gregory Poland has said so on several occasions. Multiple studies demonstrate that 2 to 10% of those immunized with 2 doses of measles vaccine fail to develop protective antibody levels. And that immunity can wane over time and result in infection, so-called secondary vaccine failure, when the individual is exposed to measles. Our current tool for prevention has limitations that increasingly look to be significant enough that sustained elimination, much less eradication, are unlikely. Perhaps it is time to consider in earnest the development of the next generation of measles vaccines. And this is shown to be true by looking at China, which has a 99% vaccination rate and doesn't allow vaccine exemptions. China has huge numbers of primary and secondary vaccine failure. Whenever I use this example, people say, oh, but Chinese people are very overcrowded and they live on top of one another. Well, how many excuses do you want to use to avoid answering the question, does the vaccine give protective immunity or not? Or do vaccines only work in people who never socialize? So let's look at China. There were over 107,000 measles case notifications in 2014, and 50,000 confirmed cases. So will they say that herd immunity needs a 110% vaccination rate in 2016? The Chinese know that the measles rates are rising despite the highest coverage possible, and they are seeing the same trends in babies and older children and adults. They also know that there might be another reason for these numbers of cases, which I'll get to in a minute. But this quote from Dr. Shi talks about the high measles vaccination coverage, that incidence rates have been rising over the last decade, that there's been a shift in the peak age of measles from young children to adolescents and younger adults. these huge number of cases are possibly due in part to vaccine escape mutants, which have nothing to do with primary or secondary vaccine failure. And if you don't know what primary or secondary vaccine failure is when you just don't respond at all to a vaccine, and secondary vaccine failure is when the vaccine wears off. And I've discussed this extensively in other videos in Scandinavia that you'll have access to. So what these doctors are now noticing is that the virus is now able to outsmart the kind of immunity that a vaccine puts into the body. And in order to understand why, new research is finally looking at what sort of immunity the vaccine gives. Dr. Finsterbusch talks about the implications of this mutant L397 variant. He says they're not easy to assess, but results obtained for other viruses point at a certain risk potential regarding escape from antibodies provided by vaccination or previous infection. And they found that there's a big difference between the ability of a naturally immune person and a vaccine immune person's blood to fight different strains of wild and vaccine measles strains. The two different groups that were looked at in this study were naturally immune mothers from Nigeria and 12-year-old vaccinated children from Luxembourg. The vaccinated children showed an inferior ability to neutralize virus compared to the naturally immune. 55% of the naturally immune and only 25% of the vaccine immune could neutralize all viruses. So the naturally immune had twice greater ability to neutralize. Only 10% of the naturally immune blood could not neutralize virus, and 50% of the vaccine immune failed to neutralize virus. So clearly, this study shows that vaccine immunity in real life, not in the lab, but in real life, is inferior. The researchers don't discuss why this is happening. In my opinion, the reason this happens is because the different receptors and layers of the immune system that the wild or natural virus goes through gives a much broader and more complete protection, which recognizes and fights off all measles viruses more efficiently. Vaccine immunity doesn't. In this Chinese study, Dr. Shi was looking at the genetic variation in 16 wild-type measles virus strains that infected 14 vaccinated cases and 2 non-vaccinated cases. And he found that all subjects were susceptible to a mutated wild-type measles virus infection. No doubt, the pro-vaccine would blame the unvaccinated, just like they did in California in 2014 and 15, for not stopping the circulation. But you could hardly do that, given that many of these mutations have arisen in China, which has the highest vaccination rates on Earth. Furthermore, the hallmark of the measles vaccine has always been that it would cover every strain and every mutation. And China is about as thoroughly vaccinated as you can possibly get. Why is this virus mutation happening? Well, it makes sense that it would first happen in China. Because China has so many people and so many vaccines, that means that they have that many viruses replicating and in that many people. And in order for mutations to happen, you need a lot of division, of replication, of production of virus, just like you do with bacteria. So the longer you hold a bacteria in your body while you're on an antibiotic, the more likely you are to generate antibiotic resistance. Well, I believe the same is true in China, and we're seeing it, the same is true of the measles, but we're seeing it in China first because they have experienced the most production of viral, the most viral production of the natural virus against these vaccinated people. So the question is, will the whole world follow at some point? Now remember, we're in a unique period right now. In the beginning of vaccinations, it looked really good because most people were already naturally immune for about 65 years or longer. And then later we started vaccinating people, which did slow down the transmission. But then these vaccinated people started to become the bigger part of the population. And now we have populations that are almost all vaccinated. And I'll talk more about that in a little bit. But nobody is answering the question as why this is happening. And they're barely talking about it at all. But it should be no surprise to you by now to know that they're saying that the current vaccine has limitations, so it's time for a second golden age era for a new measles vaccine. Just as I told you with the flu shot, saying they're saying is true for the measles. Dr. Poland has said it, and the Chinese are saying it, that because of the problems, we need to consider the development of new measles vaccines as a surrogate strategy to achieve global measles eradication. Moreover, the second golden age for measles vaccine may provide us a new sorry, that was a Freudian slip. A new insight for measles vaccine development. But the question is, why do we see less protection for the vaccinated immune than the naturally immune? To understand that, we need to understand how the body deals with wild measles and how it deals with the vaccine measles. Now, I am almost halfway through. I could continue on this track and take a break in a little while, or we could take a break now and then take another one later. It's up to you. Keep going. Okay. All right. So, yes?
May I ask a question?
Can you wait till the end?
No.
Okay.
Will you touch on mortality and morbidity related to natural infection in the non-vaccinated?
I'm sorry, say that again.
Will you touch on mortality and morbidity for the non-vaccinated versus the vaccinated for measles and all the other diseases?
Actually, yes. The answer to your question is yes. I will be getting to that very soon. A 2012 textbook makes it clear that cell-mediated immunity and not antibodies is crucial for measles survival. And the same is true for battling those secondary infections that everybody is so concerned about. So what this textbook talks about is that, that antibody is actually present after you have recovered from measles infection, but it's not necessary in order for you to recover. And the reason we know that is because of a condition called A-gamma globulinemia, where you don't produce gamma globulin and don't make antibody. And those people survive measles infections perfectly normally, and they maintain memory immunity as well, just the same way everybody else does. Whereas if you have, say, HIV/AIDS and you get infected with measles, you'll die, and nobody will even know you had measles because you don't even get a rash, and they won't realize it was measles until they do the autopsy. And that's because it's the T cells that are so important. So note this word here, iatrogenic T cell deficiency, in that paragraph. That means that it's caused by a treatment given by a doctor. And the key to no complications is that your child's innate immune system works properly. And what can toss a bomb into that, besides doctors and fever reducers? Poor nutrition is one thing for a start. In 2007, a website called the Measles Initiative had a page that's shown here. And I PDF'd it and I'm showing it to you. And they clearly identified the problems that they saw in Africa. Poor living conditions coupled with malnutrition resulting in weak immune systems. And they say measles is just one more assault on the child's already unhealthy body. And sir, this is getting to your question. So we know that these children are usually severely vitamin A deficient, with other problems we can see with the naked eye, like the swollen bellies that come from the serious protein deficiencies. And malnutrition always seriously undermines frontline defense and cell-mediated immunity, the two forms of the immune system which are crucial to clearing measles virus out of the body and preventing the complications. Where the immune systems can't control and contain measles viruses, you also have huge viral loads and out-of-control disease and a very nasty situation. But the social and nutritional reasons for the sort of death rates the Measles Initiative talks about had been largely dealt with in Scandinavia before the vaccines were used. And that's one reason why deaths were so low in Scandinavia before the vaccines were used. The situation portrayed above in Africa hasn't existed in most of the Western world for over 100 years, yet we're constantly given Africa's death results in order to tell us how serious of a disease measles is and that we should vaccinate. Okay, yes, in Western countries, measles can be dangerous, such as in ghettos in the USA and the classic slums in Glasgow, Scotland, or in fishing villages in Iceland in the 1800s, where people were convinced that infant formula mixed with water was better than mother's milk. There will always be places where children's immune systems aren't working well because the social situations they live in, the wrong messages they get from advertisers, drug companies, and miseducated doctors. Your own situation is well described by two of your own university scientists who say, around the turn of the 20th century, the great infant and child mortality peaks that had characterized the preceding century had disappeared. Even if diseases such as measles and whooping cough continued to behave as epidemics, only occurring at shorter and shorter intervals, their virulence was greatly reduced, as well as the mortality caused by them, sir. From 1916 onward, information on causes of death on the individual level is available in Iceland. At this point in time, infant and childhood mortality had dropped to levels below most other Western societies. Generally speaking, the transition from high-level to low-level infant mortality took place within an exceptionally short period of time, mainly between 1870 and 1915. By 1915, infant mortality rates in Iceland were on par with the lowest rates in Europe. And they continue. This is a 20-page paper that you can download yourself. It's called The Development of Infant Mortality in Iceland, 1800 to 1920. By this time, the great epidemic infant and child killers of the 19th century, such as measles and whooping cough, had lost much of their virulence. By 1920, Iceland had become relatively safe for infants and young children in comparison with the dreadful situation prevailing around the mid-19th century. So there you have it, published in 2002 from a historian and a statistician from your own top university in Iceland. While your earlier epidemics were vicious, like those in the mainland, your population was getting healthier, and death and virulence trends were much the same. As for instance, what we see here in Denmark. What you're looking at here in black is the death rate from measles, and what you're looking at in red are the incidence or case rates. And what's really interesting is that the cases are blossoming out of control, seemingly, and the death rate is continuing to go down all the while. And there, that blue line is where the vaccine came in. So why is this? And this is essentially this is the question that we had to answer in our book. Why is this? What else was going on? Now, vaccinologists love to say, well, it was the vaccines. That's why we didn't see the death anymore from measles. But you cannot look at that and say that's true. Something else was going on. And what was going on was that wars were going on, wars were ending. Transportation was being developed, shipping, good produce was being brought to different places. Refrigeration and electricity was invented and more widely used. Clean water became more readily available to everyone, whereas before people were essentially drinking sewage. Child labor laws were instituted, and things like that. And we discussed this all in the book. And it wasn't just Denmark and Scandinavia where this downtrend in death occurred before the vaccine. Here's England and Wales's measles mortality rate, and you can see where the vaccine was introduced over there. And these are official statistics. Same was true in the United States. Measles mortality rates, there's where your vaccine. We started vaccinating earlier than the rest of the world with not only an inefficient vaccine, but one that was actually quite dangerous. And you can see that even a small island nation like New Zealand had the same trends, declines in death long before the vaccines were introduced. The same is also true for pertussis vaccines, and you can see here's measles, whooping cough right here, and the pertussis vaccine was introduced here, and it's the green that represents pertussis, and you can see that the death was already down before the vaccine came. And what's most interesting about this slide that I think people need to pay attention to is the red line, because that red line indicates scarlet fever, which was a disease that there was a vaccine, but it was hardly ever used. So we can't congratulate any vaccine for the decline in scarlet fever deaths. But as you can see, the red line goes right down to baseline with no vaccine at all. In the United States, we had a problem with tuberculosis, but we don't anymore, at least until HIV/AIDS came along, where T-cell immunity was impaired. But our tuberculosis rates went to 0 with no vaccine at all.
Kæra áhorfendur, það okkur sönn ánægja að bjóða ykkur á seinni hluta þessa fyrirlestrar á morgun. Þar mun Dr. Humphries meðal annars leitast við að svara spurningum eins og hvernig virkar ónæmiskerfið við okkur og hversu áreiðanlegar eru bólusetningar. Góða kvöldið.